144. Diffuse liver processes. Fatty liver, very common in America. Can be focal, next to gallbladder or ligamentum teres, can be diffuse, or can be diffuse with sparing. You can call it a few different ways. For CT, fits a non-contrast study 40HU is a slam dunk. If it's contrasted, some people say you can never call it. Others say it's okay if A, it's a good portal venous phase, B, the HU is less than 100, and C, it's 25 HU less than the spleen. On US, if the liver is brighter than the right kidney, you can call it hepatosteatosis is a fat liver. NASH, hepatitis from a fat liver, has abnormal LFTs. On MRI, 2 standard deviation difference between in and out of phase imaging. Remember, the dropout is on the out of phase images. India Inc. one's done at t.e 2.2 milliseconds assuming I.st. What causes it? McDonald's, Burger King, and Taco Bell. Additional causes include chemotherapy, breast cancer, steroids, cystic fibrosis, hemochromatosis, iron overload. They can show this 2 main ways. 1. The first is just liver and spleen being TL and T2 dark. 2. The second, and more likely, way this will be shown is in and out O. Phase changes the opposite O, those seen in hepatic steatosis. Low signal on in phase, and high signal on out of phase. Iron on in phase. Watch out now, this is the opposite of the fat dropout on out of phase. India Inc. 1 t 2.2 milliseconds. Iron dropout on IN phase. Non-India Inc. 1 t 4.4 milliseconds. The second main piece of trivia is to tell primary versus secondary. Primary is the inherited type, caused by more GT uptake, with resulting iron overload. The key point is the pancreas is involved and the spleen is spared. Hemochromatosis. Secondary is the result of either chronic inflammation or multiple transfusions. The body reacts by trying to eat the iron, with the reticuloendothelial system. The key point is the pancreas is spared and the spleen is not. Primary equals pancreas, secondary equals spleen. Primary. Genetic increased absorption. Liver, pancreas. Heart, thyroid, pituitary. Secondary. Acquired chronic illness and multiple transfusions. Liver, spleen. 145. Budd-Chiari syndrome classic multiple choice scenario is a pregnant woman, but can occur in any situation where you are hypercoagulable. Most common cause is idiopathic. The result of hepatic vein thrombosis. The characteristic findings of Budd-Chiari syndrome include hepatic venous outflow obstruction, intrahepatic and systemic collateral veins, and large regenerative, hyperplastic, nodules in a dysmorphic liver. The caudate job is often massively enlarged, spared from separate drainage into the IVC. In the acute phase, the liver YJL show the classic flip-flop pattern on portal phase with low attenuation central and high peripherally. The liver has been described as nutmeg with an inhomogeneous mottled appearance and delayed enhancement of the periphery of the liver. Who gets a nutmeg liver? Budd-Chiari. Hepatic veno-occlusive disease, right heart failure, hepatic congestion, constrictive pericarditis. Regenerative, hyperplastic, nodules can be difficult to distinguish from multifocal hepatocellular carcinoma. They are bright on TL and typically dark or ISO on T2. Multiple big, 1 ocm, and small, less than 4 centimeters, nodules in the setting of Budd-Chiari suggest a benign process. T2 dark also helps. HCC is usually T2 bright. Presentation can be acute or chronopho. Acute from thrombus into the hepatic vein or IVC. These guys will present with rapid onset ascites. Chronic from fibrosis of the intrahepatic veins, presumably from inflammation. Who gets massive caudate lobe hypertrophy? Budd-Chiari primary sclerosing cholangitis primary biliary cirrhosis. Hepatic veno-occlusive disease. This is a form of Budd-Chiari that occurs from occlusion of the small hepatic venules. It is endemic in Jamaica, from alkaloid bush tea. In the US it's typically the result of XRT and chemotherapy. The main hepatic veins in LVC will be patent, but portal waveforms will be abnormal, slow, reversed, or to and fro. Passive congestion. Passive hepatic congestion is caused by stasis of blood within the liver due to compromise of hepatic drainage. It is a common complication of congestive heart failure and constrictive pericarditis. It is essentially the result of elevated CVP transmitted from the right atrium to the hepatic veins. Findings include reflux contrast into the hepatic veins, increased portal venous pulsatility, nutmeg liver. 146. Miscellaneous liver conditions. Portal vein thrombosis occurs in hypercoagulable states, cancer, dehydration, etc. Can lead to cavernous transformation, with the development of a bunch of serpiginous vessels in the porta hepatis, which may reconstitute the right and left portal veins. TIS takes like 12 months to happen. It proves portal vein is chronically occluded. Pseudocirrhosis. Treated breast cancer mets to the liver can cause contour changes that mimic cirrhosis. Specifically, multifocal liver retraction and enlargement of the caudate has been described. Why this is specific for breast cancer is not currently known, as other mets to the liver don't produce this reaction. Cryptogenic cirrhosis, essentially cirrhosis of unknown cause. Most of these cases are probably the result of non-alcoholic fatty liver disease. Liver transplant. The liver has great ability to regenerate and may double in size in as little as 3 weeks, making it ideal for partial donation. Hepatitis C is the most common disease requiring transplantation, followed by ETOH liver disease and cryptogenic cirrhosis. In adults, right lobes, segments 5 to 8, are most commonly implants. This is the opposite of pediatric transplants, which usually donates segments 2 to 3. The modem surgery has 4 connections: IVC, artery, portal vein, CBD. Contraindications include extrahepatic malignancy, advanced cardiac disease, advanced pulmonary disease, or active substance abuse. Portal HTN is not a true contraindication, although it does increase the difficulty of the surgery and increase mortality. Normal transplant. US normal Doppler should have a RA.PI diastolic upstroke diastolic systolic in less than 80 millisecond, 0.08 seconds. Resistive index is normally between 0.5 to 0.7. Hepatic artery peak velocity should be less than 200 centimeters per second. Syndrome of impending thrombosis 3 to 10 days post-transplant. First, initial normal waveform. Second, no diastolic flow. 3D, dampening systolic flow. Tardus parvus RI 0.5, 41H, loss of 1 hepatic waveform. As mentioned before, the normal liver gets 70% blood flow from the portal vein, making it the key player. In the transplanted liver, the hepatic artery is the king and is the primary source of blood flow for the bile ducts, which undergo necrosis with hepatic artery failure. Hepatic artery thrombosis comes in 2 flavors: early, less than 15 days, and later, years. The late form is associated with chronic rejection and sepsis. Trivia: Tardus parvus is more likely secondary to stenosis than thrombosis. 147. Biliary jaundice. You always think about common duct stone, but the most common etiology is. Contraindications include extrahepatic malignancy, advanced cardiac disease, advanced pulmonary disease, or biliary jaundice. You always think about common duct stone, but the most common etiology is actually from a benign stricture, post-traumatic from surgery, or biliary intervention. Bacterial cholangitis. Hepatic abscess can develop secondary to cholangitis, usually as the result of stasis, so think stones. The triad of jaundice, fever, and right upper quadrant pain is the step 1 question. Primary sclerosing cholangitis, PSC, chronic cholestatic liver disease of unknown etiology characterized by progressive inflammation, which leads to multifocal strictures of the intra- and I- or extrahepatic bile ducts. The disease often results in cirrhosis and is strongly associated with cholangiocarcinoma. The buzzword for the cirrhotic pattern is central regenerative hypertrophy. It is associated with inflammatory bowel disease, ulcerative colitis 80%, Crohn's 20%. It is an indication for transplant, with a post-transplant recurrence of about 20%. PSC buzzwords. Dilated intrahepatic bile ducts is very rare in all forms of cirrhosis, except primary sclerosing cholangitis. Withered tree, the appearance on MRCP, from abrupt narrowing of the branches. Beaded appearance, strictures plus focal dilations. AIDS cholangiopathy, infection of the biliary epithelium, classically cryptosporidium, can cause ductal disease in patients with AIDS. The appearance mimics PSC with intrahepatic and or extrahepatic multifocal strictures. The classic association/finding is papillary stenosis, which occurs 60% of the time. This versus that, AIDS cholangiopathy versus primary sclerosing cholangitis. AIDS PSC. Focal strictures of the extrahepatic duct 2 cm, extrahepatic strictures rarely greater than 5 mm. Absent saccular deformities of the ducts has saccular deformities of the ducts. Associated papillary stenosis. 148. Oriental cholangitis, recurrent pyogenic cholangitis common in Southeast Asia, hence the name. They always show it as dilated ducts that are full of pigmented stones. A buzzword is straight rigid intrahepatic ducts. The cause of the disease is not known, but it may be associated with clonorchiasis, ascariasis, and nutritional deficiency. These guys don't do as well with endoscopic decompression, and often need surgical decompression. The anatomically longer, flatter left biliary system tends to make the disease burden left dominant, the opposite of hemolysis process, which favor the right lobe. Primary biliary cirrhosis, an autoimmune disease that results in the destruction of small and medium bile ducts, intra not extra. It primarily affects middle-aged women, who are often asymptomatic. In the early disease, normal bile ducts help distinguish it from PSC. In later stages, there is irregular dilation of the intrahepatic ducts, with normal extrahepatic ducts. There is increased risk of HCC. If caught early, it has an excellent prognosis and responds to medical therapy with ursodeoxycholic acid. The step I trivia is antimitochondrial antibodies, AMA, which are present 95% of the time. 149. Choledochal cysts, iCarales. Choledochal cysts are congenital dilation of the bile ducts classified into 5 types by some dude named Todoni. The high-yield trivia is type 1 is focal dilation of the CBD, and is by far the most common. Type 2 and 3 are super rare. Type 2 is basically a diverticulum of the bile duct. Type 3 is a choledococele. Type 4 is both intra and extra. Type 5 is Carales. And is intrahepatic only. Carale S is an AR disease associated with polycystic kidney disease and medullary sponge kidney. The hallmark is intrahepatic duct dilation that is large and saccular. Buzzword is central dot sign, which corresponds to the portal vein surrounded by dilated bile ducts. Complications: cholangiocarcinoma, cirrhosis vessel in a dilated duct. Cholangitis, intraductal stones. Normotypal type 2, type 3, type 4, type S. Gamesmanship: if they give you imaging of dilated biliary ducts and a history of repeated cholangitis, think choledochal cyst. These things get stones in them and can be recurrently infected. 150. Ductal high-yield summary. Carales communicates with the duct's type 5 cyst central dot sign on CT, MR, US, associated with polycystic kidney, medullary sponge kidney, cholangiocarcinoma. Oriental cholangiohepatitis, recurrent pyogenic, associations with clonorchiasis, ascariasis. Lots of stones favors the left ductal system. Association. If you can't remember what the association is, and its ductal pathology, always guess cholangiocarcinoma. Primary sclerosing cholangitis minus 40-year-old male with UC. Withering tree beating mild dilation associated with ulcerative colitis CHO/angiocarcinoma. AIDS cholangiopathy related to cryptosporidium or cytomegalovirus. Segmental ducts look like PSC strictures, looks like PSC. Plus ill-ary stenosis. Cholangiocarcinoma versus 89 strictures. CA strictures tends to be long, with shouldering. 89 strictures tend to be abrupt and short. 151. SEC 110N4 gallbladder. Normal gallbladder. The normal gallbladder is found inferior to the interlobar fissure between the right and left lobe. The size varies depending on the last meal, but is supposed to be 4x less than iocum. The wall thickness should be less than 3 mm. Oriental cholangiohepatitis, recurrent pyogenic, associations with clonorchiasis, ascariasis. Lots of stones favors the left ductal system. Association. If you can't remember what the association is, and its ductal pathology, always guess cholangiocarcinoma. Primary sclerosing cholangitis minus 40-year-old male with UC. Withering tree beating mild dilation associated with ulcerative colitis CHO/angiocarcinoma. AIDS cholangiopathy related to cryptosporidium or cytomegalovirus. Segmental ducts look like PSC strictures, looks like PSC. Plus ill-ary stenosis. Cholangiocarcinoma versus 89 strictures. CA strictures tends to be long, with shouldering. 89 strictures tend to be abrupt and short. 151. SEC 110N4 gallbladder. Normal gallbladder. The normal gallbladder is found inferior to the interlobar fissure between the right and left lobe. The size varies depending on the last meal, but is supposed to be 4x less than iocum. The wall thickness should be less than 3 mm. The lumen should be anechoic. Variance congenital. Phrygian cap. A Phrygian cap is seen when the GB folds on itself. It means nothing. Intrahepatic gallbladder. Variations in gallbladder location are rare, but the intrahepatic gallbladder is probably the most frequently recognized variant. Most are found right above the interlobar fissure. Duplicated gallbladder. It can happen. Duct of Luschka, an accessory cystic duct. This can cause a big problem, persistent bile leak, after cholecystectomy. There are several subtypes which is not likely to be tested. GB. Accessory subvesicular, most common. GB. Ahepatocystic. Wall thickening, very nonspecific. Can occur from biliary, cholecystitis, AIDS, PSC. Or non-biliary causes, hepatitis, heart failure, cirrhosis, etc. Gallstones. Gallstones are found in 10% of asymptomatic patients / most, 75%, are cholesterol, the other 25% are pigmented. They cast shadows. Reasons a stone might not cast a shadow: it's not a stone, it's a stone, but less than 3 mm in size. The sonographer sucks. 152. Gallbladder shadowing. Gallbladder full of stones * clean shadowing. 2. Porcelain gallbladder * V raya / E shadow in. 3. Emphysematous cholecystitis * dirty shadowing. Porcelain gallbladder. Extensive wall calcification. The key point is increased risk of GB cancer. These are surgically removed. Gallbladder polyps. These can be cholesterol, by far the most common, or not cholesterol, adenomas, papillomas. Cholesterol polyps aren't real polyps, but instead are essentially enlarged papillary fronds full of lipid-filled macrophages that are attached to the wall by a stalk. The non-cholesterol subtypes are almost always solitary and are typically larger. The larger polyps may have Doppler flow. They are not mobile and do not shadow. Once they get to be 1 centimeter, people start taking them out. Adenomyomatosis results from hyperplasia of the wall with formation of intramural mucosal diverticula, Rokitansky-Askoff sinuses, which penetrate into the wall of the gallbladder. These diverticula become filled with cholesterol crystals, which manifest from the unique acoustic signature as comet tail artifact, highly specific for adenomyomatosis. Comes in 3 flavors: generalized, diffuse, segmental, annular, and fundal, localized or adenomyoma. The localized form can't be differentiated from GB cancer. 153. Clinically meaningless this versus that gallbladder adenomyomatosis versus cholesterolosis. Radiologists love to spend time distinguishing between 2 very similar appearing benign processes. They believe this adds value and will save them from the eventual avalanche of reimbursement cuts. The classic one in the gallbladder is adenomyomatosis versus gallbladder cholesterolosis. These things are actually different, and even though it makes zero difference clinically, this is just the kind of thing people who write questions love to write questions about. Gallbladder adenomyomatosis. You have hypertrophied mucosal and muscularis propria, with the cholesterol crystals deposited in an intraluminal location within Rokitansky-Askoff sinuses. Cholesterolosis. Cholesterolosis, cholesterol and triglyceride deposition. Deposition is within the substance of the lamina propria and associated with formation of cholesterol polyps. Gallbladder cancer. Key points are that most GB cancers are associated with gallstones. The outcomes are terrible, with 80% having direct tumor invasion of the liver or portal nodes at the time of diagnosis. Moritzi syndrome. This occurs when the common hepatic duct is obstructed secondary to an impacted cystic duct stone. The stone can eventually erode into the CHD, or GI tract. Key point is the increased coincidence of gallbladder CA, 5x more risk, with Moritzi. Another key piece of trivia is that Moritzi occurs more in people with a low cystic duct insertion, normal variant, allowing for a more parallel course and closer proximity to the CHD. Moritzi cystic duct stone obstructing CBD. 154. Section 5. Hepatic Doppler. Rokitansky-Askoff sinuses. Cholesterolosis, cholesterol, and gallbladder cancer. Cancer. Key points are that at the time of diagnosis. Moritzi syndrome. This occurs. Section 5. Hepatic Doppler. Brief introduction to terminology. Duplex means color. Spectral means color with a waveform. Concept of arterial resistance. Some organs require continuous flow, brain, whereas others do not, muscles. The body is smart enough to understand this, and will make alterations in resistance I flow to preserve energy. When an organ needs to be on, its arteriolar bed dilates, and the waveform becomes low resistance. This allows the organ to be appropriately perfused. When an organ goes to power save mode, its arterioles constrict, the waveform switches to high resistance, and blood flow is diverted to other more vital organs. To help quantify this low resistance high resistance thing, we use this resistive index, Ri, which is defined as VLV2/VT. Just remember that things that need blood all the time will have continuous diastolic flow and thus a low resistance waveform. V1. V2. What is this tardus parvus? Tardus refers to a slowed systolic upstroke. This can be measured by acceleration time, the time from end diastole to the first systolic peak. An acceleration time greater than 0.07 seconds correlates with greater than 50% stenos is of the renal artery. Parvus refers to decreased systolic velocity. This can be measured by calculating the acceleration index, the change in velocity from end diastole to the first systolic peak. An acceleration index 3.0 m/SCC correlates with greater than 50% stenosis of the renal artery. Normal H.artery. 155. Understanding stenosis. The vocabulary of upstream versus downstream is somewhat confusing. Try and remember that the flow of blood defines the direction. Upstream equals blood that has not yet passed through the stenosis. Downstream equals blood that has passed area of stenosis. So there are direct signs and indirect signs of stenosis. Direct signs. The direct signs are those found at the stenosis itself, and they include elevated peak systolic velocity and spectral broadening, immediate post-stenonic. Indirect signs. The indirect signs are going to be tardus parvus, downstream, with time to peak 70 millisecond. The Ri downstream will be low, 0.5, because the liver is starved for blood. The Ri upstream will be elevated, 0.7, because that blood needs to overcome the area of stenosis. It. L. High Ri increased peak velocity. Low Ri decreased peak velocity 156. Hepatic veins. Flow in the hepatic veins is complex, with alternating forward and backward flow. The bulk of the flow should be forward antegrade, liver-heart. Things that mess with the waveform are going to be pressure changes in the right heart are transmitted to the hepatic veins, CHF, tricuspid regurg, or compression of the veins directly, cirrhosis. Anything that increases right atrial pressure, atrial contraction, will cause the wave to slope upward. A represents atrial contraction. Anything that decreases right atrial pressure will cause the wave to slope downward. Abnormal hepatic vein waveforms can manifest in one of three main categories. 1. More pulsatile. 2. Less pulsatile. 3. Absent equals Bud Chiari. A. S. Above the line is retrograde, towards the liver. Below the line is antegrade, towards the heart. Increased RV, decreased HV, pulsatility, tricuspid regurg, cirrhosis. Right-sided CHF, hepatic venous outflow obstruction, any cause. Low-yield trivia study only on second time through this versus that, tricuspid regurg versus right-sided CHF. Although certain dinosaur radiologists still love this stuff, it's unlikely to show up on the test, and if it does it probably won't be more than one question. If they ask it at all, I would bet the question is something regarding the D wave to S wave relationship. Tricuspid regurg D deeper than S, right heart failure S deeper than 0. AV. Tricuspid regurg. Right heart failure, S deep to D. A. D. 157. Portal vein flow in the portal vein should always be towards the liver, antegrade. You can see some normal cardiac variability from hepatic venous pulsatility transmitted through the hepatic sinusoids. Velocity in the normal portal vein is between 20 to 40 centimeters per second. The waveform should be a gentle undulation, always remaining above the baseline. You have three main patterns: L, normal, 2, pulsatile, 3, reversed. Normal, pulsatile, reversed. Cause of portal vein pulsatility: right-sided CHF, tricuspid regurg, cirrhosis with vascular AP shunting. Causes of portal vein reversed flow: the big one is portal HTN, any cause. Absent flow: this could be considered a fourth pattern. It's seen in thrombosis, tumor invasion, and stagnant flow from terrible portal HTN. Slow flow, velocities less than 15 centimeters per second, portal HTN is the most common cause. Additional causes are grouped by location: pre-portal vein thrombosis, intracirrhosis, any cause, post-right-sided heart failure, tricuspid regurg, Budd-Chiari. Final Doppler trivia. An ultra-common quiz question is to ask what should the Doppler angle be. Now, even though ultrasound physics is covered in more detail in the dedicated section, this is a high-yield enough point to warrant repetition. The answer is less than 60. Why? Doppler strength follows the cosine of the angle. For example, cos 90 is equal to 0, cos 60 is equal to 0.5, cos 0 is equal to 1.0. The Doppler strength follows the cos. 90. 158. SEC 110 and 6 Pancreas. Trivia regarding the pancreas can be broadly clustered into solid lesions, cystic lesions, pancreatitis, and miscellaneous trivia, mostly developmental stuff. Miscellaneous pancreas trivia. Classic U.S. trivia: the pancreatic echogenicity should be greater than the normal liver. Anatomy: the pancreas is a retroperitoneal structure, the tail may be intraperitoneal. Cystic fibrosis: the pancreas is involved in 85 to 90% of CF patients. Inspissated secretions cause proximal duct obstruction, leading to the two main changes in CF: 1. Fibrosis, decreased TL and T2 signal, and the more common 1, 2, fatty replacement, increased T1. Patients with CF, who are diagnosed as adults, tend to have more pancreas problems than those diagnosed as children. Just remember that those with residual pancreatic exocrine function tend to have bouts of recurrent acute pancreatitis. They keep getting clogged up with thick secretions. Small, 1 to 3 millimeters, pancreatic cysts are common. High-yield trivia: complete fatty replacement is the most common imaging finding in adult CF. Markedly enlarged with fatty replacement has been termed lipomatous pseudohypertrophy of the pancreas. Asterisk: this is a buzzword. Fibrosing colonopathy, wall thickening of the proximal colon, as a complication of CF fatty replacement of the pancreas, enzyme replacement therapy. Schwachman-Diamond syndrome, the two most common cause of pancreatic insufficiency in kids, CF number 1. Basically, it's a kid with diarrhea, short stature, metaphyseal chondroplasia, and eczema. Will also cause lipomatous pseudohypertrophy of the pancreas. 159. Pancreatic lipomatosis, most common pathologic condition involving the pancreas. The most common cause in childhood is CF, in adults it's Burger King. Additional causes worth knowing are Cushing's syndrome, chronic steroid use, hyperlipidemia, and Schwachman-Diamond syndrome. This versus that: pancreatic agnesis versus pancreatic lipomatosis. Agenesis lipomatosis. Does have AA duct. Dorsal pancreatic agenesis. All you need to know is that 1. This sets you up for diabetes. Most Ophir beta cells are in the tail, and 2. It's associated with polysplenia. Annular pancreas, essentially an embryologic screw-up, failure of ventral bud to rotate with the duodenum, that results in encasement of the duodenum. Results in a rare cause of duodenal obstruction, I0%, that typically presents as duodenal obstruction in children and pancreatitis in adults. Can also be associated with other vague symptoms, postprandial fullness, symptoms of peptic ulcer disease, etc. Remember, in adults this can present with pancreatitis. The ones that present earlier in kids are the ones that obstruct. On imaging, Look for an annular duct encircling the descending duodenum. Pancreatic trauma. The pancreas sits in front of the vertebral body, so it's susceptible to getting smashed in blunt trauma. Basically, the only thing that matters is integrity of the duct. If the duct is damaged, they need to go to the OR. The most common delayed complication is pancreatic fistula, 10 to 20%, followed by abscess formation. Signs of injury can be subtle, and may include focal pancreatic enlargement, or adjacent stranding/fluid. Imaging pearls. Remember, it can be subtle with just focal enlargement of the pancreas. If you see low attenuation fluid separating two portions of the enhancing pancreatic parenchyma, this is a laceration, not contusion. The presence of fluid surrounding the pancreas is not specific. It could be from injury, or just aggressive hydration. On the test, they will have to show you the liver and IVC to prove its aggressive fluid resuscitation. Suspected pancreatic duct injury? Next step, MRCP or ERCP. 160. Pancreatitis. Acute pancreatitis. Etiology. By far the most common causes are gallstones and ETOH, which combined make up 80% of the cases in the real world. However, for the purpose of multiple choice tests, a bite from the native scorpion of the island of Trinidad and Tobago is more likely to be the etiology. Additional causes include ERCP, which usually results in a mild course, medications, classically valproic acid, trauma, the most common cause in a child, pancreatic cancer, infectious, post-viral in children, hypercalcemia, hyperlipidemia, autoimmune pancreatitis, pancreatic divisum, groove pancreatitis, tropic pancreatitis, and parasite-induced. Clinical outcomes. Prognosis can be estimated with the Balthazar score. Essentially, you can think about pancreatitis as mild, no necrosis, or severe, having necrosis. Patients with necrosis don't start doing terrible until they get infected, then the mortality is like 50 to 70%. Key point: outcomes are directly correlated with the degree of pancreatic necrosis. Severe pancreatitis. Severe acute pancreatitis has a biphasic course, with the first 2 weeks being a pro-inflammatory phase. This is a sterile response in which infection rarely occurs. The 3rd and 4th weeks transition to an anti-inflammatory period, in which the risk of translocated intestinal flora and the subsequent development of infection increases. Week 1 to 2 SIRS/ARDS. Week 3 to 4 infection sepsis. Let's practice. Which, the .fall/ow is the most salient, important? A. Alkmorhack in the pancreas 11D. Sounds scary, but necrosis is more important. C. Fluid collection. B. Necrosis in the pancreas, _, second best option. I'd pick D. Infection in necrosis. This if O wasn't a choice. Best option. Remember to read all the answer choices. 161. Voca cardiologist LUV to argue over words their / or line yield. For weeks JI. NO necrosis, _4 weeks. ______. For weeks necrosis 4 weeks. Vascular complications, splenic vein and portal vein thrombosis. Comma. Acute periopancreatic. Pseudocyst. _ Acute necrotic collection. Dash. WA head-off necrosis. O. Isolated gastric varices can be seen secondary to splenic vein occlusion, pseudoaneurysm of the GDA and splenic arteries. Non-vascular complications, abscess, infection, etc., as discussed. Gas, as a characteristic sign of an infected fluid collection, is detected in only 20% of cases of pancreatic abscesses. Random imaging pearl. On ultrasound, an inflamed pancreas will be hypoechoic, edematous, when compared to the liver, opposite of normal. Pancreatic divisum. Anatomy refresher. There are 2 ducts. A major, Wirsung, and a minor, Santorini. The way I remember this is that Santorini is superior, and W is in the back of the alphabet. Santorini is also small, i.e. the minor duct. Pancreatic divisum is the most common anatomic variant of the human pancreas, and occurs when the main portion of the pancreas is drained by the minor or accessory papilla. The clinical relevance is an increased risk of pancreatitis. Normal, 85%. CBD. Divisum, 15%. 162. Chronic pancreatitis, CP, represents the end result of prolonged inflammatory change leading to irreversible fibrosis of the gland. Acute pancreatitis and chronic pancreatitis are thought of as different disease processes, and most cases of acute pancreatitis do not result in chronic disease. So acute doesn't have to lead to chronic and usually doesn't, but chronic can still have recurrent acute. Etiology. Same as acute pancreatitis, the most common causes are chronic alcohol abuse and cholelithiasis, which together result in about 90% of the cases. ETOH is number 1. Imaging findings. Findings can be thought of as early or late. Loss of TL signal. Pancreas is normally the brightest TL structure in the body, delayed enhancement dilated side branches. Commonly small, uniformly atrophic, but can have focal enlargement pseudocyst formation, 30%. Dilation and beating of the pancreatic duct with calcifications, most characteristic finding of CP. This versus that, chronic pancreatitis duct dilation versus pancreatic malignancy duct dilation. CP cancer. Dilation is irregular, dilation is uniform, usually. Duct is less than 50% of the AP gland diameter. Duct is greater than 50% of the AP gland diameter, obstructive atrophy. Complications. Pancreatic cancer, 20 years of CP equals 6% risk of cancer, is the most crucial complication in CP, and is the biggest diagnostic challenge, because focal enlargement of the gland induced by a fibrotic inflammatory pseudotumor may be indistinguishable from pancreatic carcinoma. 163. Uncommon types and causes of pancreatitis. Autoimmune associated with absence of attack responds to sausage-shaped pancreatitis, elevated IgG4 symptoms, steroids, pancreas, capsule IIC, delayed rim enhancement around gland, like a scar. Groove duodenal and duodenal stenosis, soft tissue within the pancreatitis, biliary obstruction, and slash or strictures of pancreaticoduodenal symptoms overlap the CBD in 50% of groove, with or with pancreatic, the cases without delayed cancer enhancement. Tropic young age at onset, increased risk of multiple large calculi pancreatitis associated with adenocarcinoma within a dilated malnutrition pancreatic duct. Hereditary young age at onset, increased risk of SPFNK1 gene similar to tropic pancreatitis, adenocarcinoma pancreatitis. Ascaris, most commonly worm, may be seen induced implicated parasite within the bile ducts in pancreatitis. When I say autoimmune pancreatitis, I say autoimmune pancreatitis, you say LGG4. Autoimmune pancreatitis, retroperitoneal fibrosis, I say IgG4, sclerosing cholangitis, inflammatory pseudotumor, renal thyroiditis. This versus that, autoimmune pancreatitis versus chronic pancreatitis. Autoimmune pancreatitis, chronic pancreatitis. No ductal dilation, ductal dilation. No calcifications, ductal calcifications. 164. Cystic pancreatic lesions. Pseudocyst. When you see a cystic lesion in the pancreas, by far the most common cause is going to be an inflammatory pseudocyst, either from acute pancreatitis or chronic pancreatitis. Simple cysts, true epithelial-lined cysts, are rare and tend to occur with syndromes such as VHL, polycystic kidney disease, and cystic fibrosis. Serous cystadenoma. Grandma, the former term microcystic adenoma, helps me think of a little old lady, which is appropriate for a lesion primarily found in elderly ladies. The lesion is benign and classically described as heterogeneous mixed-density lesion, made up of multiple small cysts, which resembles a sponge. They are more commonly, 70%, located in the pancreatic head. Mucinous is almost always in the body or tail. An additional key distinction is that it does not communicate with the pancreatic duct, JPMNs do. About 20% of the time they will have the classic central scar. With or without central calcifications, mucinous calcifications are peripheral. Rarely, they can be unilocular. When you see a unilocular cyst with a lobulated contour located in the head of the pancreas, you should think about this more rare uni-ocular macrocystic serous cystadenoma subtype. Trivia: serous cystadenoma is associated with von Hippel-Lindau memory aid. Grandma Serous is the head of the household. Mucinous cystic neoplasm, mother. This premalignant lesion is always found in women, usually in their 50s. All are considered premalignant and need to come out. They are found in the body and tail. Serous was more common in the head. There is generally no communication with the pancreatic duct. JPMNs will communicate. Peripheral calcifications are seen in about 25% of cases. Serous was more central. They are typically unilocular. When multilocular, individual cystic spaces tend to be larger than 2 cm in diameter. Serous spaces are typically smaller than 2 cm. Memory aid: mucinous in the mother. 165. IPMN intraductal papillary mucinous neoplasm. These guys are mucin-producing tumors that arise from the duct epithelium. They can be either side branch, main branch, or both. Side branch, O, typically appear as a small cystic mass, often in the head, or uncinate process, O. If large amounts of mucin are produced, it may result in main duct enlargement, O. Lesions less than 3 cm, as usually benign. Main branch, O, produces diffuse dilation of the main duct, O. Atrophy of the gland, and dystrophic calcifications may be seen mimicking chronic pancreatitis, O. Have a much higher percent of malignancy compared to side branch, O. All main ducts are considered malignant, and resection should be considered. Features concerning for malignancy: O. Main duct 1 ohm, some sources say 1.5 cm, O. Diffuse or multifocal involvement, O. Enhancing nodules, O. Solid hypovascular mass. Solid pseudopapillary tumor of the pancreas, daughter. Very rare, low-grade malignant tumor that occurs almost exclusively in young, 30s, females, usually Asian or black. It is typically large at presentation, has a predilection for the tail, and a thick capsule. Similar to a hemangioma, it may demonstrate progressive fill-in of the solid portions. 166. Cystic pancreatic lesion summary. Main branch IPMN. The bad one has malignant potential. Side branch IPMN common one has much less malignant potential. Solid pseudopapillary. Daughter lesion solid with cystic parts, enhances like a hemangioma capsule. Serous cystic. Mucinous cystic mother lesion premalignant body, tail 95% unilocular with thick wall septations. Grandma lesion benign microcystic, with central calcifications. 167. Solid pancreatic lesions. Pancreatic cancer basically comes in 2 flavors. 1. Ductal adenocarcinoma, which is hypovascular, and 2. Islet cell neuroendocrine, which is hypervascular. Ductal adenocarcinoma. In the setting of a multiple-choice test, the finding of an enlarged gallbladder with painless jaundice is highly suspicious for pancreatic adenocarcinoma, especially when combined with migratory thrombophlebitis, Trousseau-S syndrome. The peak incidence is in the 7th, or GTH decade. The strongest risk factor is smoking. Approximately 2/3 of these cancers arise from the pancreatic head. On ultrasound, obstruction of both the common bile duct and the pancreatic duct is referred to as the double duct sign. On CT, the findings are typically a hypovascular mass, which is poorly demarcated and low attenuation, compared to the more brightly enhancing background parenchyma. The key to staging is assessment of the SMA and celiac axis, which if involved make the patient's cancer unresectable. Involvement of the GDA is okay, because it comes out with the Whipple. Additional trivia points about pancreatic adenocarcinoma. Tumor marker equals CA19 to 9. Hereditary syndromes with pancreatic CA, OHNPGC, BRCA mutation, ataxia-telangiectasia, Peutz-Jeghers small bowel follow-through, reverse impression on the duodenum Frostberg's inverted 3 sign, or a wide duodenal sweep. They would have to actually find a case of the inverted 3 to show it, but could ask it in words. The wide duodenal sweep could actually be shown. Periampullary tumor, defined as originating within 2 centimeters of the major papilla. It can be difficult to differentiate from a conventional pancreatic adenocarcinoma, as both obstruct the bile duct and present as a mass in the pancreatic head. Basically, all you need to know about them is they can try and treat them with a Whipple, and they have a better prognosis than pancreatic adenocarcinoma. Trivia: there is an increased incidence of ampullary carcinoma in Gardner's syndrome. 168. Islet cell neuroendocrine. Neuroendocrine tumors are uncommon tumors of the pancreas. Typically hypervascular, with brisk enhancement during arterial or pancreatic phase. They can be thought of as non-functional or functional, and then subsequently further divided based on the hormone they make. They can be associated with both MEN1 and von Hippel-Lindau. Hyperenhancing tumor. Insulinoma, the most common type, about 75%. They are almost always benign, 90%, solitary, and small, less than 2 centimeters. Gastrinoma, the second most common type overall, but most common type associated with men. They are malignant like 30 to 60%. They can cause increased gastric acid output and ulcer formation Zollinger-Ellison syndrome. The buzzword is jejuna. Ulcer equals Zollinger-Ellison. Non-functional, the third most common type, usually malignant, 80%, and are usually large and metastatic at the time of diagnosis. I say non-functional, you say large with calcification. Unterpancreatic accessory spleen. It is possible to have a pancreatic mass that is actually just a piece of spleen. The typical scenario is that of post-traumatic splenosis. Look for the question stem to say something like history of trauma. Another hint may be the absence of a normal spleen. Imaging findings: mass follows spleen on all image sequences, dark on TL, and bright on T2 relative to the liver. It will restrict diffusion, just like the spleen. The classic giveaway, and most likely way it will be shown is as a tiger-striped mass on arterial phase, tiger-striped like the spleen on arterial phase. Trivia: nuclear medicine tests: 1. Heat-treated RBC, and 2. Sulfur colloid can be used to prove the mass is spleen. They both take up tracer just like a spleen. 169. SEC 110N1 surgical. The Whipple procedure. The standard Whipple procedure involves resection of the pancreatic head, duodenum, gastric antrum, and almost always the gallbladder. Ajejunal loop is brought up to the right upper quadrant for gastrojejunal, cholecocojejunal, or hepatocojejunal, and pancreatojejunal anastomosis. An alternative method used by some surgeons is to perform a pancreatoduodenectomy to preserve the pylorus when possible. However, there is debate in the surgery literature with regard to which method should be the standard. In this pylorus-preserving pancreatoduodenectomy, the stomach is left intact and the proximal duodenum is used for a duodenojejunal anastomosis. Whipple. Complications. Delayed gastric emptying, need/or NG tube longer than 1 day, and pancreatic fistula, amylase through the surgical drain 50 ml for longer than 7 to 10 days, are both clinical diagnoses and are the most common complications after pancreatoduodenectomy. Wound infection is the third most common complication, occurring in 5%-20% of patients. 170. Transplant. Pancreas transplant, usually with a renal transplant, is an established therapy for severe type 1 diabetes, which is often complicated by renal failure. The vascular anatomy regarding this transplant is quite complicated and beyond the scope of this text. Just know that the pancreas transplant receives arterial inflow from two sources, the donor SMA, which supplies the head via the inferior pancreaticoduodenal artery, and the donor splenic artery, which supplies the body and tail. The venous drainage is via both the donor portal vein and the recipient SMV. Exocrine drainage is via the bowel, in older transplant via the bladder. The number 1 cause of graft failure is acute rejection. The number 2 cause of graft failure is splenic vein thrombosis. Splenic vein thrombosis usually occurs within the first 6 weeks of transplant. Venous thrombosis is much more common than arterial thrombosis in the pancreas, especially when compared to other transplants, because the vessels are smaller, and the clot frequently forms and propagates from the tied-off stump vessels. Both venous thrombosis and acute rejection can appear as reversed diastolic flow. Arterial thrombosis is also less of a problem because of the dual supply to the pancreas via the Y-graft. A point of trivia is that the resistive indices are not of value in the pancreas because the organ lacks a capsule. The graft is also susceptible to pancreatitis, which is common 4 weeks after transplant and usually mild. Increased rates of pancreatitis were seen with the older bladder-drained subtype. Shrinking transplant is a buzzword for chronic rejection, where the graft progressively gets smaller in size. 171. Ecno-NS spleen. Normal trivia. By the age of 15, the spleen reaches its normal adult size. The spleen contains both red pulp and white pulp, which contribute to its tiger-striped appearance during arterial phase imaging. The red pulp is filled with blood, a lot of blood, and can contain up to 1 liter of blood at any time. The spleen is usually about 20 HU less dense than the liver, and slightly more echogenic than the liver, equal to the left kidney. The splenic artery, which usually arises from the celiac trunk, is essentially an end vessel, with minimal collaterals. Occlusion of the splenic artery will therefore result in infarct of the spleen. Pathology involving the spleen can be categorized as either congenital, acquired, as the sequela of trauma, or portal hypertension, or related to a mass. A general rule is that most things in the spleen are benign with exception of lymphoma, or the rare primary Ong-10 sarcoma. Normal spleen on MRI. The spleen is basically a big watery lymph node. It's bright on T2 relative to the liver, it's dark on T1 relative to the liver. Just like a lymph node, it will restrict diffusion. Heterotaxy syndromes, super high yield. Please see discussion on page 58. 172. Accessory spleens, these are very common, we see them all the time. Some random trivia that might be testable includes the fact that sulfur colloid could be used to differentiate a splenule from an enlarged pathologic lymph node. Additionally, in the scenario where a patient is post-splenectomy for something like ITP or autoimmune hemolytic anemia, an accessory spleen could hypertrophy and present as a mass. Hypertrophy of an accessory spleen can also result in a recurrence of the original hematologic disease process. Wandering spleen, a normal spleen that wanders off and is in an unexpected location. Because of the laxity in the peritoneal ligaments holding the spleen, a wandering spleen is associated with abnormalities of intestinal rotation. The other key piece of trivia is that unusual locations set the spleen up for torsion and subsequent infarction. A chronic partial torsion can actually lead to splenomegaly or gastric varices. Trauma. The spleen is the most common solid organ injured in trauma. This, combined with the fact that the spleen contains a unit or so of blood, means splenic trauma can be life-threatening. Remember, the trauma scan is done in portal venous phase, 72nd. Otherwise, you'd have to tell if that tiger-striped arterial phase spleen is lacerated. Splenosis. This occurs post-trauma, where a smashed spleen implants and then recruits blood supply. The implants are usually multiple and grow into spherical nodules, typically in the peritoneal cavity of the upper abdomen, but can be anywhere. It's more common than you think, and has been reported in 40 to 60% of trauma. Again, TC sulfur colloid, or heat-treated RBC, can confirm that the implants are spleen, and not ovarian mets, or some other terrible thing. Gamma antibodies, siderotic nodule. These are small foci of hemorrhage in the splenic parenchyma that are usually associated with portal hypertension. They are T2 dark. Gradient is the most sensitive sequence. Gamma antibodies. 173. Sarcoidosis. Sarcoid is a disease of unknown etiology that results in non-caseating granulomas and forms in various tissues of the body. Complete discussion in the chest section of this text. The spleen is involved in 50–80% of patients. Splenomegaly is usually the only sign. However, aggregates of granulomatous splenic tissue in some patients may appear on CT as numerous discrete 1 to 2 cm hypodense nodules. Rarely, it can cause a massive splenomegaly and possibly rupture. Don't forget that the gastric antrum is the most common site in the GI tract. Peliosis. This is a rare condition characterized by multiple blood-filled cyst-like spaces in a solid organ, usually the liver. Peliosis hepatitis. When you see it in the spleen, it is usually also with the liver. Isolated spleen is extremely rare. The etiology is not known, but for the purpose of multiple choice tests it occurs in women on OCPs, men on anabolic steroids, people with AIDS, renal transplant patients, up to 20%, and Hodgkin lymphoma. It's usually asymptomatic, but can explode spontaneously. Splenic vascular abnormalities. Splenic artery aneurysm is the most common visceral arterial aneurysm. Pseudoaneurysm can occur in the setting of trauma and pancreatitis. The incidence is higher in women of childbearing age who have had 2 or more pregnancies, 4x more likely to get them, 3x more likely to rupture. It's usually saccular and in the mid to distal artery. They usually fix them when they get around 2 to 3 centimeters. Major F up to avoid. Don't call them a hypervascular pancreatic islet cell mass and biopsy them. Splenic vein thrombosis frequently occurs as the result of pancreatitis. Can also occur in the setting of diverticulitis or Crohn's. Can lead to isolated gastric varices. Infarction can occur from a number of conditions. On a multiple-choice test, the answer is sickle cell. The imaging features are classically a wedge-shaped, peripheral, low attenuation defect. 174. Splenic infections. Most common radiologically detected splenic infection is histoplasmosis, with multiple round calcifications. Splenic TB can have a similar appearance, but much less common in the U.S. Another possible cause of calcified granuloma in the spleen is brucellosis, but these are usually solitary and 2 centimeters or larger. They may have a low-density center, encircled by calcification, giving the lesion a bullseye appearance. In the immunocompetent patient, splenic abscess is usually due to an aerobic organism. Salmonella is the classic bug which develops in the setting of underlying splenic damage, trauma, or sickle cell. In immunocompromised patients, unusual organisms such as fungi, TB, MAI, and PCP can occur and usually present as multiple microabscesses. Occasionally, fungal infections may show a bullseye appearance on ultrasound. Splenic size too big versus too small. It's good to have a differential for a big spleen and a small spleen. Small spleen, big spleen, sickle cell, passive congestion, heart failure, portal HTN, splenic vein thrombosis. Post-radiation lymphoma, post-thoratrast leukemia, malabsorption syndromes, ulcerative Gaucher's colitis, Crohn's. Feltes syndrome, abnormality of granulocytes, with a triad of 1. Splenomegaly, 2. Rheumatoid arthritis, 3. Neutropenia. 175. Benign masses of the spleen. Cysts. Post-traumatic cysts, pseudocysts, are the most common cystic lesion in the spleen. They can occur secondary to infarction, infection, hemorrhage, or extension from a pancreatic pseudocyst. As a point of trivia, they are pseudocysts because they have no epithelial lining. They may have a thick wall or prominent calcifications peripherally. Epidermoid cysts are the second most common cystic lesion in the spleen. They are congenital in origin. As a point of absolutely worthless trivia, they are true cysts and have an epithelial lining. They typically grow slowly and are usually around 1 ohm at the time of discovery. They can cause symptoms if they are large enough. They are solitary 80% of the time and have peripheral calcifications 25% of the time. Hydatid or echinococcal cysts are the third most common cystic lesion in the spleen, most common worldwide. They are caused by the parasite Echinococcus granulosus. Hydatid cysts consist of a spherical mother cyst that usually contains smaller daughter cysts. Internal septations and debris are often referred to as hydatid sand. Another sign described is the water lily sign. The water lily sign is seen when there is detachment of the endocyst membrane resulting in floating membranes within the pericysts, looks like a water lily. This was classically described on CXR in pulmonary echinococcal disease. Hemangioma is the most common benign neoplasm in the spleen. This dude is usually smooth and well marginated, demonstrating contrast uptake and delayed washout. The classic peripheral nodular discontinuous enhancement seen in hepatic lesions may not occur, especially if the tumor is smaller than 2 centimeters. Lymphangiomas are rare entities in the spleen, but can occur. Most occur in childhood. They may be solitary or multiple, although most occur in a subcapsular location. Diffuse lymphangiomas may occur, lymphangiomatosis. Hamartomas are also rare in the spleen, but can occur. Typically this is an incidental finding. Most are hypodense or isodense and show moderate heterogeneous enhancement. They can be hyperdense if there is hemosiderin deposition. Littoral cell angioma is a zebra that shows up occasionally in books and possibly on multiple choice tests. Clinical hypersplenism is almost always present. Usually presents as multiple small foci, which are hypoattenuating on late portal phase. Mr. shows hemosiderin, low TL and T2. 176. L. Malignant masses of the spleen. Most things that occur in the spleen are benign. Other than lymphoma, discussed below, it is highly unlikely that you will encounter a primary malignancy of the spleen, but if you do, it's likely to be vascular. For the purposes of academic discussion and possible multiple-choice trivia, angiosarcoma is the most common. Angiosarcoma, it is aggressive and has a poor prognosis. On CT it can manifest as a poorly defined area of heterogeneity, or low density, in an enlarged spleen. They can contain necrosis and get big enough to rupture. Spontaneous rupture occurs like 30% of the time. Contrast enhancement is usually poor. Yes, these can occur from prior thorotrast exposure. Lymphoma is the most common malignant tumor of the spleen, and is usually seen as a manifestation of systemic disease. Splenomegaly is the most common finding, and may be the only finding in low-grade disease. Although both Hodgkin's and non-Hodgkin's types can involve the spleen, Hodgkin's type and high-grade lymphomas can show discrete nodules of tumor. With regard to imaging, they are low density on CT, TL dark, and are PET hot. Metastatic disease to the spleen is rare. When it does occur, it occurs via common things: breast, lung, melanoma. Trivia: melanoma is the most common primary neoplasm to met to the spleen. 177. Section 1. Anatomy I congenital. Normal anatomy. The normal adult kidney is shaped like a bean, with a smooth, often lobulated, outer border. The kidney is surrounded by a thick capsule outlined by echogenic perirenal fat. This echogenic fat is contiguous with the renal sinus, filling the middle of the kidney. The cortex extends centrally into the middle of the kidney, separated by slightly less echogenic medullary pyramids. The normal kidney should be between 9 cm and 15 cm in length. Papilla, tip of medulla projecting into calyx. The echogenicity of the kidney should be equal to or slightly less than the liver and spleen. If the renal echogenicity is greater than the liver, this indicates some impaired renal function, medical renal disease. Liver echogenicity greater than the kidney indicates a fatty liver. Variant anatomy. Fetal lobulation. The fetal kidneys are subdivided into lobes that are separated with grooves. Sometimes this lobulation persists into adult life. The question is always: fetal lobulation versus scarring. Fetal lobulation. Renal scarring. Lobulation equals renal surface indentations overlie the space between the pyramids. Indentations between pyramids. Indentations over pyramids. Scarring equals renal surface indentations overlie the medullary pyramids. Dromedary hump. Focal bulge on the left kidney, which forms as the result of adaptation to the adjacent spleen. 180. Prominent, or hypertrophied, column of Bertin. Normal variant, in which hypertrophied cortical tissue located between the pyramids results in splaying of the sinus. Other than the hypertrophy, it looks totally normal. It will enhance the same as adjacent parenchyma. Most likely to be shown on ultrasound, looks like a big echogenic cortex. On CT or MR it would be too easy. Prominent column of Bertin. Renal agenesis. Congenital absence of one or both kidneys. If it's unilateral, this can be asymptomatic. If it's bilateral, think about the Potter sequence. When it's unilateral, it's usually sporadic, but for the purpose of multiple choice, think about associated GYN anomalies in women. 70% of women with unilateral renal agenesis have associated genital anomalies. Unicornuate uterus. With regard to men, 20% with renal agenesis have absence of the ipsilateral epididymis and vas deferens, or an ipsilateral seminal vesicle cyst. Associations: ipsilateral seminal vesicle cysts, absent ipsilateral ureter, absent ipsilateral hemitrigone, and absent ipsi.lateral vas deferens. Potter sequence, insult, maybe ACE inhibitors, equals kidneys don't form. If kidneys don't form, you can't make piss. If you can't make piss, you can't develop lungs, pulmonary hypoplasia. O.M. Erokotansky-Kusterhauser. Mullerian duct anomalies including absence or atresia of the uterus. Associated with unilateral renal agenesis. A lying down adrenal or pancake adrenal sign describes the elongated appearance of the adrenal not normally molded by the adjacent kidney. It can be used to differentiate surgically absent versus congenitally absent. Horseshoe kidney. This is the most common fusion anomaly. The kidney gets hung up on the IMA. Complications include traumatic injury, gets crushed against vertebral body, UPJ obstruction, recurrent infection, recurrent stones, Wilms tumor, 8x higher, TCC, from all those infections. A rare situation, but known association, is the renal carcinoid occurring in horseshoe kidney. Turner's syndrome is a classically tested association. Crossed fused renal ectopia. One kidney comes across the midline and fuses with the other. The ectopic kidney is inferior. The left kidney more commonly crosses. Complications include stones, infection, and hydronephrosis, 50%. 181. SEC 110N2 renal masses. Renal cell carcinoma. The most common primary renal malignancy. RCC till proven otherwise. A. Enhances with contrast. 15HU. B. Calcifications in a fatty mass. Risk factors include tobacco use, syndromes like VHL, chronic dialysis, 3 years, family history. These dudes make hypervascular mets. Their AL weighs lytic when they met to the bones. Pseudo-enhancement, a less than 10 HU increase in attenuation, is considered within the technical limits of the study, and is not considered to represent enhancement. More rare once a cyst is larger than L.5 cm. Can RCC have fat in it? Oh yeah, for sure, especially clear cell. This leads to the potential sneaky situation of a fat-containing lesion in the liver, which can be a RCC met. Now to make this work they'd have to tell you the patient had RCC or show you one. A helpful hint is that RCCs with macroscopic fat nearly always have some calcification/ossification. If they don't, it's probably an AML. Subtypes: clear cell, most common subtype. This is the one that is associated with VHL. It is typically more aggressive than papillary, and will enhance equal to the cortex on corticomedullary phase. Papillary: this is the second most common type. It is usually less aggressive than clear cell. More rare subtypes can be very aggressive. They are less vascular, and will not enhance equal to the cortex on corticomedullary phase. They also are in the classic T2 dark differential, along with lipid-poor AML and hemorrhagic cyst. Medullary: associated with sickle cell trait. It's highly aggressive and usually large and already metastasized at the time of diagnosis. Patients are usually younger. Chromophobe: all you need to know is that it's associated with Birt-Hogg-Dubé. Conventional RCC staging. Stage 1. Limited low kidney and 7 cm S1 age 2, limited to kidney, but greater than 7 cm stage 3, still inside garrula S fascia A, renal vein invaded B, IVC below diaphragm C, IVC above diaphragm stage 4, beyond garrota fascica ipsilateral adrenal. Subtype syndrome I association. Clear cell von Hippel-Lindau. Papillary hereditary papillary renal care MO ma chromophobe Birt-Hogg-Dubé __ medullary sickle cell trait. Timing nephrogram phase 82nd equals most sensitive for detection of RCC. 182. Sneaky move. Does adult polycystic kidney disease increase your risk for RCC? Well, no, but sorta. The genetic syndrome does not intrinsically increase your risk. However, dialysis does. Who gets dialysis? People with ADPKD. It would be such a crap way to ask a question BW could happen. Or if I were asked, I'm recommending you say no to the increased risk, unless the Wesleyan writer specifies that the patient is on dialysis. Renal masses that are not RCC. Renal lymphoma: this can literally look like anything. Having said that, the most common appearance is bilateral, enlarged kidneys, with small, low attenuation cortically based solid nodules or masses. A solitary mass is seen in about 1/4 of the cases. Trivia: out of all the renal masses, lymphoma is the most likely to preserve the normal reniform shape. Renal leukemia: the kidney is the most common visceral organ involved. Typically the kidneys are smooth and enlarged. Hypodense lesions are cortically based only, with little if any involvement of the medulla. Angiomyolipoma, AML: this is the most common benign tumor of the kidney. Almost always, 95%, of them have macroscopic fat, and this is the defining feature. They are usually incidental, in the real world. The things to know about them are: 1. They are associated with tubular sclerosis. 2. They can bleed if they get big enough, greater than 4 centimeters. It's controversial if they grow or bleed more in pregnancy. If they ask you, I guess you should say yes, because that's the old knowledge, but some modern papers are saying not for sure. 3. They should never have calcifications. That's probably a RCC. 4. They can be lipid poor, about 5% are, and those are T2 dark. Gamesmanship: traditional spectral fat sat or in and out of phase, India Inc., can be used to suggest an AML. Just remember, rarely RCCs can have fat. Fat with calcifications equals RCC. Fat with no calcifications equals probably AML. 183. Oncocytoma: this is the second most common benign tumor, after AML. It looks a lot like a RCC, but has a central scar 33% of the time, and 100% of the time on multiple choice. There will be no malignant features, such as vessel infiltration. They cannot be distinguished from RCC on imaging, and must be treated as RCC till proven otherwise. If they want to ask about an oncocytoma, they can show it 3 ways. 1. solid mass with central scar CT, or MRI. 2. On ultrasound spoke will vascular pattern. 3. On PET CT it will be hotter than the surrounding renal cortex. Gamesmanship. I have encountered two types of GU radiologists in my life. The first type is the practical type. She doesn't ever even mention oncocytoma, because enhancing renal masses have to come out. Even if you biopsy it and get oncocytes, it doesn't matter, because RCCs can have oncocytic features. The second type is more of your classic academic type. To try and sound impressive, this person will often include this, and other rare entities, in the differential. Another common psychopathology in these types is excessive word Nazism. Don't say that, say this. Am fairly certain you have met this person. There is usually one in every section. So if you are shown an enhancing renal mass with a central scar, how do you decide if it's a RCC or an oncocytoma? The way to figure it out is simple. Just read the mind of the person who wrote the question. If it's a practical type, then all enhancing renal masses are RCC till proven otherwise. If it's the academic type, then central scar equals oncocytoma. You may also think, which of these two people is more likely to volunteer to write board questions? Trivia. A syndrome associated with bilateral oncocytomas is Birt-Hogg-Dubé. They also get chromophobe RCC. Multilocular cystic nephroma, non-communicating, fluid-filled locules, surrounded by thick fibrous capsule. By definition, these things are characterized by the absence of a solid component, or necrosis. Buzzword is protrudes into the renal pelvis. The question is likely the bimodal occurrence, for year old boys, and 40-year-old women. I like to think of this as the Michael Jackson lesion. It loves young boys and middle-aged women. The PET trick. RCC is typically colder than surrounding renal parenchyma on PET. Oncocytoma is typically hotter than surrounding renal parenchyma on PET. 184. SECR10N3. Cystic disease. Bosniak cyst classification. Class 1, simple less than 15 HU with no enhancement. Class 2, hyperdense, less than 3 cm. Thin calcifications, thin septations. Class 2F, hyperdense, greater than 3 cm. Minimally thickened calcifications, 5% chance cancer. Class 3, thick septations, mural nodule, 50% chance cancer. Class 4, any enhancement, 15 HU. Class 1, Class 2, Class 2F, Class 1, Class 2, Class 2F, simple anechoic hyperdense, less than 3 cm, hyperdense, greater than 3 cm, 0% chance of CA. Thin calcifications. Class 3, thick calcifications, mural nodule, thin septations, less than 5% chance of CA minus 50% chance of CA, 0% chance of CA. Class 4, any enhancement minus 100% chance of CA. Hyperdense cysts. Basically, if the mass is greater than 70 HU, and homogeneous, it's benign, hemorrhagic, or proteinaceous cyst, 99.9% of the time. Autosomal dominant polycystic kidney disease, ADPKD, kidneys get progressively larger and lose function. You get dialysis by the 5th decade. Hyperdense contents and calcified wall are frequently seen due to prior hemorrhage. What you need to know is, 1. It's autosomal dominant ADPKD. 2. They get cysts in the liver 70% of the time. 3. They get seminal vesicle cysts, some sources say 60%, and 4. They get berry aneurysms. As mentioned before, they don't have an intrinsic risk of cancer, but do get cancer once they are on dialysis. Autosomal recessive polycystic kidney disease, ARPKD, these guys get HTN and renal failure. The liver involvement is different than the adult form. Instead of cysts, they have abnormal bile ducts and fibrosis. This congenital hepatic fibrosis is always present in ARPKD. The ratio of liver and kidney disease is inversely related. The worse the liver is, the better the kidneys do. The better the liver is, the worse the kidneys are. On ultrasound, the kidneys are smoothly enlarged and diffusely echogenic, with a loss of corticomedullary differentiation. Uremic cystic kidney disease. About 40% of patients with end-stage renal disease develop cysts. This rises with duration of dialysis in about 90% in patients after 5 years of dialysis. The thing to know is, increased risk of malignancy with dialysis, 3-6x. Trivia: the cysts will regress after renal transplant. 185. Von Hippel-Lindau autosomal dominant multisystem disorder. 50 to 75% have renal cysts. 25 to 50% develop RCC, clear cell. Pancreas, cysts, serous microcystic adenomas, neuroendocrine, islet cell, tumor adrenal, pheochromocytoma, often multiple, CNS, hemangioblastoma of the cerebellum, brainstem, and spinal cord. Tuberous sclerosis autosomal dominant multisystem disorder. You have hamartomas everywhere: brain, lung, heart, skin, kidneys. The renal findings are bilateral multiple angiomyolipomas. They also have renal cysts, and occasionally RCC, same rate as general population, but in younger patient population. With regard to other organ systems, lung LAM thin-walled cysts and chylothorax cardiac rhabdomyosarcoma typically involve cardiac septum, brain giant cell astrocytoma, cortical and subcortical tubers, subependymal nodules, renal AMLs, RCC, in younger patients. Lithium nephropathy occurs in patients who take lithium long-term. Can lead to diabetes insipidus and renal insufficiency. The kidneys are normal to small in volume with multiple, innumerable, tiny cysts, usually 2 to 5 millimeters in diameters. These microcysts are distinguishable from larger cysts associated with acquired cystic disease of uremia. They are probably going to show this on MRI with a history of bipolar disorder. ADPKD cysts in liver, IVHL cysts in pancreas. Kidneys are BLG. Acquired lion, S are small, your IC. 186. Multicystic dysplastic kidney. This is a PEDS thing, where you have multiple tiny cysts forming in utero. What you need to know: 1. That there is no functioning renal tissue. 2. Contralateral renal tract abnormalities occur like 50% of the time. MCDK versus bad hydro? In hydronephrosis, the cystic spaces are seen to communicate. In difficult cases, renal scintigraphy can be useful. MCDK will show no excretory function. Peripelvic cyst versus parapelvic cyst. Peri originates from renal sinus, mimics hydropara, originates from parenchyma, may compress the collecting system. T2 dark renal cyst. Cysts are supposed to be T2 bright. If you see the T2 dark cyst, then you are dealing with the classic differential of 1. Lipid poor AML. A small percentage of AMLs are lipid poor in the general population. For the purpose of multiple choice, if you see a lipid poor AML, especially if you see a bunch of them, you need to think about tuberous sclerosis. About 30% of their AMLs are lipid poor. 2. Hemorrhagic cyst. These will likely be T1 bright. 3. Papillary subtype RCC. Remember that clear cells, the most common subtype, are T2 hyperintense. Both clear cell and papillary will enhance, but the clear cell enhances more avidly, equal to cortex on corticomedullary phase. 187. SECR10N4 infections. Pyelonephritis. This is a clinical diagnosis. However, you do end up diagnosing it. It's associated with stones. The most common organism is E. coli. In acute bacterial nephritis, alternating bands of hypo and hypertenuation, striated nephrogram, are seen. These wedge-shaped areas are related to decreased perfusion. Perinephric stranding is also commonly seen. Striated nephrogram DDX. Acute ureteral obstruction, acute pyelonephritis, medullary sponge kidney, acute renal vein thrombosis, radiation nephritis, acutely following renal contusion, hypotension, bilateral, infantile polycystic kidney, bilateral. Abscess pyelo may be complicated by abscess, which can present on CT as round or geographic low attenuation collections that do not enhance centrally, but do have an enhancing rim bigger than 3 centimeters, and these guys might visit the IR section for drainage. Chronic pyelonephritis, sort of a controversial entity. It is not clear whether the condition is an active chronic infection, arises from multiple recurrent infections, or represents stable changes from a remote single infection. The imaging findings are characterized by renal scarring, atrophy, and cortical thinning, with hypertrophy of residual normal tissue. Basically, you have a small deformed kidney, with a bunch of wedge defects, and some hypertrophied areas. Emphysematous pyelonephritis. This is a life-threatening necrotizing infection characterized by gas formation within or surrounding the kidney. What you need to know: 1. It's really bad. 2. Diabetics almost exclusively get it. 3. Echogenic foci with dirty shadowing on ultrasound. Emphysematous pyelitis. This is less bad relative to emphysematous pyelonephritis. The gas is localized to the collecting system. It's more common in women, diabetics, and people with urinary obstruction. Radiographic finding is gas outlining the ureters and dilated calyces. Emphysematous pyelonephritis 188. Pyonephrosis, an infected or obstructed collecting system, which is frequently enlarged. Can be from a variety of causes: stones, tumor, sloughed papilla secondary to pyelonephritis. Can totally jack your renal function if left untreated. Fluid level in the collecting system can be seen on US CT. Has trouble telling the difference between hydro and pyonephrosis. Xanthogranulomatous pyelonephritis, XGP, chronic destructive granulomatous process that is basically always seen, with a Staghorn stone acting as a nidus for recurrent infection. You can have an associated psoas abscess with minimal perirenal infection. It's an ant mini, with a very characteristic bear paw appearance on CT. The kidney is not functional, and sometimes nephrectomy is done to treat it. Xanthogranulomatous pyelonephritis, bear paw. Papillary necrosis. This is ischemic necrosis of the renal papillae, most commonly involving the medullary pyramids. Diabetes is the most common cause. Other important causes include pyelonephritis, especially in kids, sickle cell, TB, analgesic use, and cirrhosis. Filling defects might be seen in the calyx. The appearance of a necrotic cavity in the papillae with linear streaks of contrast inside the calyx has been called a lobster claw sign. Trivia: 50% of sickle cell patients develop papillary necrosis. 189. TB. The most common extrapulmonary site of infection is the urinary tract. There are features of papillary necrosis and parenchymal destruction. You can have extensive calcification. Basically, you end up with a shrunken, calcified kidney, putty kidney. This end-stage appearance is essentially an autonephrectomy. The Kerr kink is a sign of renal TB with scarring leading to a sharp kink at the pelviureteric junction. HIV nephropathy, normal-sized, or big, kidneys that are echogenic on US. Loss of the renal sinus fat appearance has also been described. It's edema in the fat, rather than loss of the actual fat. Disseminated PCP in HIV patients can result in punctate, primarily cortical, calcifications. Contrast-induced nephropathy, CIN. The more you read about this, the more you realize it's probably complete, or at least near complete, bullshit. But some academic people have made a career on it, so we have to treat it like it's a real thing. In your abundant free time, read this paper and become enlightened. I will warn you. If you are a follower of conventional wisdom, you think books need to be published under a conventional publisher to be legitimate, you think screening mammography improves mortality, or you think the NSA is protecting you by recording all your cell phone conversations, this paper may make you cry. Davenport, Matthew S. ETAL. The challenges in assessing contrast-induced nephropathy. Where are we now? American Journal of Röntgenology 202.4, 2014 784 to 789. Trivia to know: allergic reactions are not considered a risk factor for CIN. Risk factors for CIN include pre-existing renal insufficiency, diabetes mellitus, even more so with pre-existing renal insufficiency, cardiovascular disease with CHF, dehydration, and myeloma hydration via 4 with 0.9% normal saline 6 to 12 hours before, and continuing 4 to 12 hours after contrast administration supposedly decreases the incidence of CLN in patients with chronic renal insufficiency. True mechanism is diluting CR levels. Oral hydration has been shown to not work as well. 190. SECR10NS calcifications. Nephrolithiasis, kidney stones. There are several different stone types. The most likely testable trivia for each is calcium oxalate, by far the most common type, 75%. Struvite stone, more common in women, and associated with UTI, uric acid unseen on X-ray. Cysteine, rare and associated with congenital disorders of metabolism. Indinavir stones in HIV patients, which are the only stones not seen on CT. Treatment trivia. There are two pieces of trivia that matter with regard to treatment. Size matters. Stones measuring 5 mm or smaller have a high likelihood of spontaneous passing. Stones measuring LCM or larger have a high likelihood of not passing spontaneously. Composition: uric acid versus not uric acid. Uric acid stones very rarely will require any kind of invasive intervention, lithotripsy, etc. The reason is they are very pH dependent. Big fat people and or diabetics tend to have more acidic urine, from AGI that Mountain Dew, which leads to an increase in uric acid stones. They can be treated with medical therapy, potassium citrate, or sodium bicarbonate, to increase the pH and melt the stones. You can't melt a calcium stone by messing with the pH. Diagnosis of uric acid stones. Since identification of a uric acid stone is going to change management, that makes it a target for trivia on multiple choice. There are two things that I would know. 1. Uric acid stones tend to have lower attenuation, 500 HU. 2. Uric acid stones will have little if any change in HU with dual energy CT. The reason is they are composed of light elements. The larger atoms, calcium, phosphorus, magnesium, and sulfur, tend to have a larger change, which is the basis of dual energy CT, 80 kV, and 140 kV, identification of stone composition. Trivia: non-uric acid stones will have higher HU at 80 kVp relative to 140 kVp. Trivia: uric acid stones will be very similar to 80 kVp relative to 140 kVp. Asterisk: if they do show a small change, it will be the opposite, with a slightly higher HU at 140 kVp. Trivia: calcium stones are going to show the biggest HU change between high and low energies. In general, low/high energy ratios are going to be around 1.1 for uric acid, 1.25 for cysteine, and 1.25 for calcium. 191. Cortical nephrocalcinosis. This is typically the sequela of cortical necrosis. WHLCH can be seen with an acute drop in blood pressure, shock, postpartum, burn patients, etc. It starts out as a hypodense non-enhancing rim that later develops THLN calcifications. Mimic is disseminated PCP. Medullary nephrocalcinosis, hyperechoic renal papilla, pyramids, which may or may not shadow. There are multiple causes. The most common of WHLCH is probably hyper-PTH. A few texts say medullary sponge kidney is most common. Other things to think about include Lasix use in a child, renal tubular acidosis, distal subtype or type I, medullary sponge kidney if asynonetric. RTA and hyperparathyroid usually cause a more dense calcification than medullary sponge kidney. Medullary nephrocalcinosis, hyperechoic pyramids that shadow. Medullary sponge kidney, a congenital cause of medullary nephrocalcinosis, usually asymmetric. The underlying mechanism is a cystic dilation of the collecting tubules of the kidney, so the testable association with Ehlers-Danlos makes sense. The association with Carolis sorta makes sense. The association with Beckwith-Weidman doesn't really make sense, and therefore is the most likely to be tested. Think about medullary sponge kidney with unilateral medullary nephrocalcinosis. Page kidney sequela of long-standing compression of the kidney by some kind of subcapsular collection, hematoma, or seroma. The classic scenario is post-lithotripsy subcapsular hematoma, with follow-up showing a shrunk-up kidney. 192. This versus that, delayed versus persistent nephrogram. Delayed nephrogram, one kidney enhances, and the other doesn't, or does to a lesser degree. Basically, this is happening from pressure on the kidney, either extrinsic from a page kidney situation, or intrinsic from an obstructing stone. Persistent nephrogram, this is seen with hypotension/shock and ATN. They can show this several ways. One would be on a plain film of the abdomen, with dense kidneys, the second would be on CT. The tip-offs are going to be that they tell you the time, 3 hours etc., and it's gonna be bilateral. Delayed nephrogram. Renal infarct, so wedge-shaped hypodensities in the kidney can be seen with lots of stuff, infarct, tumor, infection, etc. Renal infarcts are most easily identified on post-contrast imaging in the cortical phase. If the entire renal artery is out, well then it won't enhance, duh. Two tricks that they could pull are the 1. Cortical rim sign, which is absent immediately after the insult, but is seen 8 hours to days later. You have a dual blood supply, which allows the cortex to stay perfused. 2. Flip-1 flop enhancement can be seen, where a region of hypodensity, at poor enhancement, on early phases becomes relatively hyperdense on delayed imaging. Persistent nephrogram. Renal vein thrombosis, numerous causes including dehydration, indwelling umbilical venous catheters, most common in neonates, and nephrotic syndrome, most common in adults. This can mimic a renal stone, presenting with flank pain, an enlarged kidney, and a delayed nephrogram. On Doppler they are going to show you reversed arterial diastolic flow and absent venous flow. Asterisk, this is discussed again below in the transplant section. 193. SECR10N6 trauma. Obviously the kidney can get injured in trauma, seen in about 10%. Injury can be graded based on the presence of hematoma-laceration-involvement of the vein, artery, or UPJ obstruction. Gamesmanship, a good next step type question in the setting of renal trauma, or pelvic fracture, would be to prompt you to get delayed imaging. This is helpful to demonstrate a urine leak. Terminology. Fractured kidney, a laceration, which extends the full length of the renal parenchyma. By definition, the laceration must connect two cortical surfaces, so think about it going all the way through. Shattered kidney, this is a more severe form of a fractured kidney. A kidney with 3 or more fragments, this is the most severe form of renal fracture. Wedge-shaped perfusion abnormality, think segmental artery injury. Renal trauma, rapid pearls. Diffuse non-perfusion, think devascularized kidney. Persistent nephrogram, think renal vein injury, thrombosis. 194. SEC110N1 transplant. Renal transplant is the best treatment for end-stage renal disease, and the quality of life is significantly better than that of a long-term dialysis patient. The transplanted kidney is most commonly placed in the extraperitoneal iliac fossa, so that the allograft can be anastomosed with the iliac vasculature and urinary bladder. Normal, a transplant kidney is just like a native kidney. It should have low resistance, it's always on. The upstroke should be brisk, and the flow in diastole forward, remember it's always on. Significance of RIS. If the meat of the kidney becomes sick from whatever the cause might be, rejection, infection, inflammation, etc., it starts to increase resistance. This increased resistance raises URT. The higher the RL, the sicker the kidney. This is why RLS are useful, and this is why an upward trend in RI is worrisome. RLs should stay below 0.7, higher than that should trigger you to think something is wrong. You can think of complications in three main flavors: A. Urologic, B. Vascular, C. Cancer. Urologic complications. Urinoma. This is usually found in the first 2 weeks post-OP. Urine leak, or urinoma, will appear as an anechoic fluid collection, with no septations, that is rapidly increasing in size. MAG3 nuclear medicine scan can be used to demonstrate this, or the cheaper ultrasound. Hematoma. Common immediately post-OP, usually resolves spontaneously. Large hematoma can produce hydro. Acute hematoma will be echogenic, and this will progressively become less echogenic, with older hematomas more anechoic and septate. Lymphoceles typically occur 1 to 2 months after transplant. They are caused by leakage of lymph from surgical disruption of lymphatics. The fluid collection is usually medial to the transplant, between the graft and the bladder. They are actually the most common fluid collection to cause transplant hydronephrosis. Buzzword equals ipsilateral lower extremity edema from femoral vein compression. Acute rejection IATN. Up to 20% of transplant patients will have some early rejection. Both ATN and acute rejection tend to occur in the first week or so. On ultrasound, the pyramids become prominent, the transplant itself gets bigger, and the RLS go up. ATN versus acute rejection is best distinguished on MAG3, where the ATN has normal perfusion, and the rejection does not. Both will have delayed excretion. Chronic rejection. This occurs 1 year post-transplant. The kidney may enlarge, and you can lose corticomedullary differentiation. The RLS will elevate 0.7, which is nonspecific. Calculus disease. Compared with the general population, transplant kidneys are at increased risk of stone formation. 195. Vascular complications. Renal vein thrombosis typically seen within the first week. Typically the kidney is swollen. Instead of showing you the Doppler of the renal vein, which would show no flow, they will most likely show you the artery, which classically has reversed diastolic flow. Renal vein thrombosis with the artery showing reversal of diastolic flow. Some people call this the reverse M sign. Reverse diastolic flow. Renal artery thrombosis usually seen within the first month. Typically caused by kinking, hypercoagulation, or hyperacute rejection. Delayed, late, thrombosis is often due to stenosis. Renal artery stenosis typically seen within the first year after transplant, usually weeks to months. Occurs in 5 to 10% renal transplants, which makes it the most common vascular complication of transplant. This usually occurs at the anastomosis, especially end-to-end types. The clinical scenario buzzword is going to be refractory hypertension. Criteria include PSV 200 to 300 mFs. PSV ratio 3.0, external iliac artery IRA, tardus parvus, measured at the main renal artery hilum, not at the arcuates, anastomotic Jennings. Arteriovenous fistula, AVF, these occur secondary to biopsy. They occur about 20% of the time post-biopsy, but are usually small and asymptomatic. They will likely show it with tissue vibration artifact, paravascular, mosaic color assignment due to tissue vibration, with high arterial velocity and pulsatile flow in the vein. Pseudoaneurysm. These also occur secondary to biopsy, but are less common. They can also occur in the setting of graft infection or anastomotic dehiscence. They will most likely show you the classic yin-yang color picture. Alternatively, they could show Doppler with a biphasic flow at the neck of the pseudoaneurysm. 196. Cancer in the transplant. The prolonged immunosuppression therapy that renal transplant patients are on places them at significantly 1-ox increased risk of developing cancer. RCC increased risk, with most of the cancers, 90%, actually occurring in the native kidney. Etiology is not totally understood, Maybe it's the immunosuppression, or the fact that many transplant patients were on dialysis, a known risk factor that leads to the cancer risk. In reality, it doesn't matter, and is probably both. Post-transplant lymphoproliferative disorder, PTLD. This is an uncommon complication of organ transplant, associated with B-cell proliferation. It is most common in the first year post-transplant, and often involves multiple organs. The treatment is to back off the immunosuppression. Cyclophosphamide is a point of trivia. Significant exposure to cyclophosphamide, just common now with the development of cyclosporin A, is associated with increased risk of urothelial cancer. Week 1 renal vein thrombosis urinoma. Hematoma. Weeks 1 to 4 renal artery thrombosis lymphocytic. Months 1 to 6 renal artery stenosis, common, lymphocytic. Biopsy-related injury, pseudoaneurysm, AV fistula, drug toxicity. After 6 months chronic rejection. RCC. L-lymphoma. PTLD. 197. SEC 110 NA ureters. Normal anatomy. The ureters run anterior to the psoas muscle and empty at lateral angles of the bladder trigone. They have 3 layers, with the inner layer being transitional epithelium. Developmental ureter anomalies. Congenital, primary, MEG order. This is a wastebasket term for an enlarged ureter, which is intrinsic to the ureter, as opposed to the result of a distal obstruction. Causes include 1. Distal adenamic segment, analogous to achalasia, or colonic Hirschsprung's. 2. Reflux at the UVJ. 3. It just wants to be big, totally idiopathic. The distal adenamic type obstructing primary megaureter can have some hydro, but generally speaking an absence of dilation of the collecting system helps distinguish this from an actual obstruction. Most cases just have dilation of the lower 1/3. It is almost always unilateral, favoring the left side. Retrocaval ureter, circumcaval. Although the name implies that this is the result of a maldeveloped ureter, it's actually a developmental anomaly of the IVC. Most of the time it's asymptomatic, but can cause partial obstruction and recurrent UTI. IVP will show a reverse J or fishhook appearance of the ureter. Duplicated system. The main thing to know about duplicated systems is the so-called Weigert-Meyer rule, where the upper pole inserts inferior and medially. The upper pole is prone to ureterocele formation and obstruction. The lower pole is prone to reflux. Upper. Lower. I. 0 Weigert-Meyer rule. Upper pole inserts medial and inferior. 198. Ureterocele. A cystic dilation of the intravesicular ureter, secondary to obstruction at the ureteral orifice. IVP will show the cobra head sign, with contrast surrounded by a lucent rim, protruding from the contrast-filled bladder. This is associated with a duplicated system, specifically the upper pole. Ureteroceles are best demonstrated during the early filling phase of the VCUG. There is a picture of this in the PEDS chapter, page 51. Pseudoureterocele. This is an acquired dilation of the submucosal portion of the distal ureter. A loss of the normal lucent line around the cobra head suggests a pseudoureterocele. Causes include an impacted stone, a recently passed stone, and a bladder malignancy. Ectopic ureter. The ureter inserts distal to the external sphincter in the vestibule. More common in females and associated with incontinence, not associated with incontinence in men. Vesicoureteral reflux refers to retrograde flow of urine. The supposed malfunction is that the course of the ureter is too short as it crosses the bladder, messing with the ureteral valve mechanism. This is really a PEDS thing, and discussed more in the PEDS chapter. Congenital UPJ obstruction. This is the most common congenital anomaly of the GU tract in neonates.